most of the patients I see are, very scared. They've heard the word cancer, or they've heard the word, you have a tumor or a mass in your kidney. And that's usually the extent of the information they have. So they come into clinic being very scared about their diagnosis and what the next steps are. And some of them may be Googling things and maybe they're getting good information, maybe not. So really my first step is to educate the patient and kind of explain where they are in their disease and what treatments we have to offer. And a lot of times I'm giving them a little bit more hope than maybe they initially came in with.
Well, good morning and welcome to episode 7 in season 1 of our Winnovations webinar turned podcast series. I'm your host, Dr. Kyle A. Richards, and we really have a great program planned for this morning. Just to refresh, the purpose of these podcasts is to highlight some of the exciting and innovative work being done at the University of Wisconsin in the Department of Urology. We also want to generate discussion within the broader urology community so that we can continue to work together to make innovative advancements in urologic care. We are planning to continue with this format in the future, and we'll be releasing additional podcasts in the next few months, so stay tuned for these releases. But without further ado, I'd like to introduce my guest for this morning, Dr. Dan Shapiro. Dr. Shapiro joined our department in 2021 after completing his fellowship training at MD Anderson in Urologic Oncology. He did his residency here at UW-Madison, and we were fortunate enough to recruit him back to his roots here in the Midwest. In addition to his clinical practice, he conducts clinical, translational, and basic science research related to kidney cancer, and he's very passionate about his topic for today, which is advancing kidney care via multidisciplinary collaboration. Dr. Shapiro, welcome to the program.
Thank you. Thanks for having me.
And just on a personal note, when we were looking to hire another urologic oncologist, the timing worked out perfectly for Dr. Shapiro to come back, and I was just thrilled when he joined our group.
Well, thank you. I'm flattered. Pleasure to be here.
Let's dive into the discussion for this morning. Tell us your story about kidney cancer, Dan. How did you get interested in the first place? And we can sort of build off of that.
Yeah, so I started out getting interested in urology in medical school, didn't really know much about it until then. And I had a mentor in the Department of Urology here at UW, Dr. Tracy Downs. And so I was interested in urologic oncology from the beginning, but my passion for kidney cancer really came during residency when I was exposed more to the surgery aspect of the management of kidney cancer. And, I think doing a nephrectomy or a partial nephrectomy, they're very elegant surgeries, and I really loved the anatomy and the physiology of the kidney. And then once I started learning more about kidney cancer, I thought it was a very interesting disease process. And so I just sort of fell in love with it from there. And then I continued investigating it during my fellowship, and now I continue doing research and seeing patients and treating it to this day. So yeah, it's been a long journey, but it's something I really love.
That's great to hear. And getting back to, when you're seeing a patient in clinic, let's say you're seeing a patient in clinic with a new kidney cancer diagnosis. How do you begin that discussion with them, and what do you say to them?
Yeah, I think the big thing is most of the patients I see are very scared. They've heard the word cancer, or they've heard the word, you have a tumor or a mass in your kidney. And that's usually the extent of the information they have. So they come into clinic being very scared about their diagnosis and what the next steps are. And some of them may be Googling things and maybe they're getting good information, maybe not. So really my first step is to educate the patient and kind of explain where they are in their disease and what treatments we have to offer. And a lot of times I'm giving them a little bit more hope than maybe they initially came in with, because we do have a lot of treatment options for kidney cancer. And a lot of times, nowadays with the implementation of broad scanning, people are getting CT scans. We're finding kidney cancers at much smaller sizes and lower stages than maybe previously before we had a lot of imaging. And so a lot of times these are very treatable tumors, and that's kind of how I start the discussion. And hopefully by the end of our discussion, the patient's leaving with a little more hope and feeling a little more at ease. So yeah, I think it's hard, when a patient comes in and all they've heard is you have a mass in your kidney.
Yeah, I mean, I think for me in the bladder cancer world, it's the same thing. These patients come in, they're very anxious and nervous, and I think it takes a lot of skill to put them at ease and help walk them through the process, and a lot of education. A little bit of education, I think, goes a long way with a new cancer diagnosis. So what do you think are some of the more exciting or more important areas that people are working on to advance kidney cancer care here at University of Wisconsin?
Yeah, I think, it's hard to pin down one area in particular. We're doing a lot here at UW investigating kidney cancer through a lot of different approaches. So from a clinical standpoint, we investigate a lot of the clinical outcomes of patients, particularly after surgery, trying to identify and appropriately select the best patients for surgery versus patients who may be better suited to other treatment modalities, of which we have a lot now. So we can treat kidney cancer, surgically, which is typically what I'm seeing patients for, but we also have a pretty big ablation program, which we use, particular patients who maybe have a smaller renal mass and more comorbidities. So we've done a lot of investigation into how to appropriately select patients for surgery versus ablation. And then we're also looking at it from more of a basic and translational standpoint. So some of my research is investigating more of the immune microenvironment and potentially using that as a prognostic biomarker for localized kidney cancer. And then we're also have a good collaboration with our radiology colleagues, and we're doing radiomic evaluations of kidney tumors and seeing if those may be prognostic, and also trying to identify kidney tumors and their histology even without a biopsy. So using their imaging that they come in with and seeing if we can tell just based on the radiomic signatures what type of tumor they have, even potentially what grade the tumor is. So is it a high-grade tumor versus a low-grade tumor? And now we're trying to even correlate our radiomic findings with the immune microenvironment. So we're looking at kidney cancer from a lot of different angles, and I think it's been really great, and we have really strong collaborations with our partners in medical oncology and radiology and basic scientists, and so we're trying to hit kidney cancer from every different angle.
One of the key things I heard you say is multidisciplinary, right? Kidney cancer is not being managed in a silo. Is that safe to say? So can you just talk a little bit more about what that means, maybe in people that don't treat kidney cancer every day, more layman's terms? What does it mean by what do you mean by that, and how does that actually work in sort of real world practice?
Yeah, I think nowadays just the urologist managing kidney cancer, localized kidney cancer alone is kind of going by the wayside. So if we have, for example, even with like a small renal mass, perhaps a patient is comorbid or a high-risk surgical candidate and needs something less invasive, but we still need to control the kidney tumor. Oftentimes we'll offer them an ablation therapy. And so in order to do that, we collaborate with our colleagues in radiology, and we actually have sort of a radiology ablation tumor board. And we meet once a week and we discuss cases, and we go over the imaging with the radiologists in order to determine, is this patient an ideal candidate? What's the risk of damaging surrounding structures if we do an ablation? And so having the input from radiology and urology really helps with selecting the best patients for that treatment. Now, we also have our weekly tumor board where we discuss more complex cases with medical oncology, radiology, and radiation oncology, as well as we have our pathologists weigh in if there's any concerns or questions about the biopsy or tissue specimens. And so having all of these people weigh in on what the ideal management is for someone with a more complex case is really helpful for getting the best treatment to each patient. Oftentimes, people with like metastatic disease that can both be treated from a medical oncology standpoint with immunotherapies and TKIs, but also there is still a role for surgery in advanced disease as well. And figuring out what the timing of each should be, should the patient be treated with systemic therapy first and then go to surgery, or should surgery be offered up front and then the patient get systemic therapy if they have metastatic disease? those are the questions that we discuss all together as a group. And that's what's really important about having a team that's really skilled in managing kidney cancer, because these are complex discussions, and oftentimes the answer to these discussions is not clear. And so we need to come to a consensus together. And that's sort of what the multidisciplinary approach is kind of putting all our heads together and figuring out the best solution.
Yeah, that's awesome to have built that up here at UW, and I think clearly provides the best possible urologic kidney cancer care for our patient populations.
Yeah, and I think, it's helpful too for advancing the field, because we work together, surgeons, medical oncologists, radiation oncologists, to identify trials that are good for our kidney cancer patients, and enrolling patients in, the latest trial that may be helpful to advance the field in the future and deliver even better therapies than what we have now.
And that makes me think of something that our visiting professor said yesterday. Dr. Arthur Bud Burnett was here, and he talked a lot during his visit. He's from Johns Hopkins. Talked a lot about cross-pollination, or going outside your field to advance the field, because sometimes a pathologist thinks about things differently than a urologist does. And does that work with kidney cancer as well?
Oh yeah, definitely. Like in my research, I work heavily with pathologists, and it's really helpful to have their insight and also to learn kind of how they evaluate kidney tumors. And you learn a lot about new technologies, new ways that the tissue is being analyzed by having these collaborations, like in my example, having these collaborations with pathology, and also, discussing the cases with radiology, and then also having them involved in research. There's a wide range of new technologies in radiology. I touched on that a little bit previously, but the whole explosion of research into radiomics, and really we have so much data from every CT scan and MRI that's being done, and we're not using it, and we're trying to use it better and identify, are there aspects of these imaging studies that we can analyze using computers and artificial intelligence to determine if we can even get a biopsy just radiographically without even doing a physical biopsy. So can we use an MRI or a CT scan to determine, is this a high-grade tumor? Is this a clear cell carcinoma versus a non-clear cell carcinoma? And as we get better and better at using these technologies, we'll be able to offer less and less invasive treatment options to our patients.
Just to elaborate a little bit more on the radiology piece of things. So renal mass biopsy is an invasive, somewhat invasive procedure, I think is safe to say. Does have, low risk of complications, as I think the group here at UW has published. Also, I think UW has been sort of pushing the needle, so to speak, when it comes to needle biopsy of renal masses. So why, with the advances at UW and safety and efficacy of needle mass biopsy, why is there a need to shift away from that then into this sort of, non-invasive biopsy? How has that sort of shifted, so to speak?
Yeah, I think, we have published previously, Dr. Abel has done a lot of work with renal mass biopsy. Dr. Abel is one of our partners here at UW. We have shown that renal mass biopsy is a relatively benign procedure, but the complication rate is not zero. And if we had an option that was less invasive or non-invasive compared to a renal mass biopsy, that could still tell us the information we needed to know, like, is this a cancerous tumor? Is it an aggressive tumor? If we had something that was less invasive or non-invasive, obviously that would be preferable for patients. I mean, patients don't want to have a needle passed into their kidney a few times if they can avoid it. So the work we're doing with radiology, looking at these radiomic signatures, is really to try and advance the field to the point where we don't even need a biopsy, where we could use just our radiologic exams to determine exactly what the tumor is. Now, we're still a long way off from that, but we are making progress. The difficulty with radiomics is you get a lot of information. You can imagine there's a lot of data with every CT scan that we get. And so kind of teasing through all this data that we're getting and generating and figuring out what are the critical components of this data. Like, there's multiple different radiomic signatures. You can look at the entropy, the kurtosis, the pixel gray level distributions. And so trying to figure out which of these variables is important and how do these variables correlate with what we're finding pathologically. And so that's really what the focus of our studies is to correlate what we're finding with these radiomic signatures to what we're finding pathologically and figuring out what of these variables is the most important that we should focus on and we could use in the future to figure out what these kidney tumors are.
Now, I know we can't predict the future as much as our patients oftentimes ask us to do so. In your heart and in your mind, do you feel like at some point we'll get there with radiomics that we won't need to do an invasive biopsy?
I tend to be more optimistic. I like to think that, yes, someday we will get to that point. We're definitely a far way from that. But I mean, I think the research that we're doing, and especially with the more advanced artificial intelligence that's being developed, we're going to just get better and better at analyzing this data. And I think one day, we will be able to tell what a kidney tumor is without needing a biopsy. But I don't know how long it's going to be until that point, but I hope that in my career we see something like that. And that's why we're doing this research, is so that one day that can be a possibility.
I'm hopeful as well, and hopefully we'll see that happen. I think that'd be a great advance for our patients. And, as long as we understand the science and follow the science, I think we'll get there at some point. I want to move a little bit away from radiology and radiomics and focus a little bit now, Dan, on the immune microenvironment in kidney cancer. I know it's an area that you're passionate about. There have been a lot of seminal advances in kidney cancer using targeted therapies. Right? Many of these therapies take advantage of our own immune system, right? Immunologic agents, immunotherapies, which is fascinating. So can you elaborate on some of these advances maybe more broadly, and then speak to the role then about this sort of microenvironment and kidney cancer, more specific maybe to some of the work that you've been doing?
Yeah, sure. So just to start more broadly, as you mentioned, there's been an explosion of new treatments for kidney cancer over the last 5 to 10 years. Kidney cancer now, especially in the advanced stages with metastatic disease, is primarily being managed with immune checkpoint inhibitor therapy. And so these therapies really target your immune system and kind of take the brakes off of the immune system and allow the patient's own immune system to then target and kill the tumor cells. And we found, compared to our older, tyrosine kinase inhibitors, that these immune checkpoint inhibitors are much more effective at treating kidney cancer patients. And so there's been a lot of research in this area and a lot more effective therapies that are now being offered to our patients. And we're seeing really good results. Now, they do come with some toxicities that we have to be aware of. But overall, I think these are very exciting and very helpful for our patients. And now we're even moving into more of the localized setting. So we were primarily treating patients with metastatic disease with immune checkpoint inhibitors, but now there's been a lot of research and clinical trials investigating patients who just have a localized disease. So if a patient comes in with a tumor just in their kidney and then we take out that kidney and they have no disease in the rest of their body, can we give them additional immune therapy after their surgery to prevent that tumor from ever coming back? And so there has been one trial so far using pembrolizumab, which has shown improved disease-free survival after surgery if patients get immune therapy. And these are highly selected patients that have more aggressive disease and are more likely to recur in the future. But all of this is just showing that kidney cancer is a very immune-sensitive disease. And even before the advent of all these new modern immune checkpoint inhibitors, some of the first systemic therapies for kidney cancer targeted the immune system. If you think back to the very first systemic therapies, it was interleukin-2 and interferon alpha. And those therapies basically were to ramp up the patient's immune system, but they were just, they were more broadly activating the immune system. So they weren't as effective as the more modern therapies, but it just goes to show that kidney cancer is very immune sensitive, and it's important to have a robust and effective immune response in order to control the disease. That's kind of what makes me interested in the immune microenvironment in kidney cancer, because it does seem to be really important for controlling the disease. And so a lot of the research that I've been investigating is sort of looking at how does the body effectively organize an immune response, and do certain tumors elicit a more effective immune response. And so a lot of what I've been looking at is sort of tissue-based studies, looking at how the immune cells spatially organize next to the tumors, evaluating which tumors elicit a more robust immune response, and then trying to figure out, can we look at a patient's own immune cells in the tumor microenvironment and see if those immune cells are prognostic? So if the patient has a more robust immune response, are those patients less likely to have a recurrence in the future? Or perhaps they're more likely to have a recurrence in the future because the tumor is very aggressive and causing the body's immune system to react very vigorously. It's a very complex area of research because there's so many different factors at play. You've got the patient's immune system, which is incredibly complex. You have the tumor itself and the microenvironment that the tumor creates, which is very complex, and then trying to figure out how those two areas interact with each other. So it's a lot to unpack, and we have a lot of people working on it simultaneously with me, and I've been trying to kind of build up a team of experts looking at kidney cancer specifically. But I think, we're getting some preliminary results that are pretty interesting, and my ultimate goal is to try and find a prognostic biomarker, particularly in the localized disease setting, to figure out if we can better predict which patients are going to progress in the future, and maybe those patients are more ideal candidates for getting these adjuvant immune therapies in the future.
That's just fascinating work, and it's always amazed me how cancer evades our immune system. Right, our immune system is trying to eradicate cancer, yet cancer has sort of figured out a way to evade the immune system. And with these immunotherapies, these immunologic agents, you're sort of taking off the brakes and trying to get a more robust immune response. I know you've got a lot of work to still do in this area, but do you think, there are certain phenotypes or certain kidney cancers where it's become so good at evading the immune system that even the current immunotherapies that we have are not effective? Is that one of the theories or hypotheses?
Yeah, as good as our current immune checkpoint inhibitors are, there's still a large proportion of patients that don't respond well to the therapies, or perhaps they respond well initially, but then their disease progresses later on, and then we don't have as effective agents to treat them. And so the immune checkpoint inhibitors, while being an amazing advance, and I was at MD Anderson, and there's Jim Allison down there who got the Nobel Prize for developing these immune checkpoint inhibitors. As amazing as these therapies are, there's still a lot of patients that don't benefit much from them. So there's still a lot of work to figure out the immune microenvironment and figure out, just like you said, how are the tumors evading our own immune system? And the tumor it's a very interesting, because the tumor itself can find ways to avoid the immune system. It can downregulate surface proteins that the immune system uses to recognize a tumor. It can produce substances that kind of downregulate the immune system's response. And so the tumors are they're tricky beasts. And so we still have a lot of work to do to identify more effective therapies, whether it be in the immune system or other, targetable therapies for other pathways in the tumor. There's still a lot of work to be done. And that's kind of what we're trying to do.
Yeah, and understanding that sort of unique tumor biology, following the science again, will develop innovation.
Yeah, I think it's going to be the next 10 years are going to be very interesting, and there's going to for sure be a lot of new developments in kidney cancer, because the pace at which the research is being done is incredible. I mean, There are new papers coming out every day identifying new potential targets for kidney cancer, identifying how to stimulate the patient's own immune system to fight the tumors. So there's a lot of work being done, and I think, any patient with kidney cancer should be hopeful that we're going to develop more and more effective therapies.
You used a buzzword that I want to go back to. Biomarkers is sort of the word that I picked up on, and can really be I think a buzzword in cancer biology. Just for maybe some of our non-cancer surgeons or cancer scientists listening in, can you talk a little bit about what a biomarker is, and then are there any currently that we're using for kidney cancer, or is that sort of what we're trying to get to?
Yeah, so biomarker research is a very broad topic. So biomarker, just kind of simply, biomarkers are essentially any sort of substance or variable that you can measure from a patient that help us either predict or prognosticate patient outcomes. And so what do I mean by predict or prognosticate? So you can have biomarkers that predict a certain response to a therapy. So maybe there's a biomarker that can predict whether or not a patient is going to respond well to an immune checkpoint inhibitor. And then there are biomarkers that simply prognosticate. So maybe there's a certain variable that you measure in a patient, and it tells you or gives you a better idea of how long that patient is going to survive or how long it's going to be until that patient recurs. So you have biomarkers that are both predictive of therapy and then prognostic of patient outcomes. And biomarker research is difficult because a lot of biomarkers are developed in a very specific patient population. So you develop a biomarker using a small sample of patients, and the biomarker works really well for that sample of patients. But then you take that biomarker and try and apply it to a broad group of patients more, globally. And then the biomarker doesn't work as well because it was developed in a very specific group of patients. And so that's the challenge with sort of biomarker research, is figuring out some sort of variable or substance that you can measure and having it work well for a really broad group of people. And that's often very difficult to develop. And it's also difficult to make sure that biomarker is also very cost effective. So it's a difficult area of research, but it's incredibly important because those are the things we need to really give that individualized therapy to each patient. So if we have a biomarker that we can sit down with one patient and say, okay, if we know your biomarker is this level, then the therapy we give you is probably going to work. Versus I sit down with the next patient and say, okay, because of the biomarker, we know the therapy is not going to work. That's really what we need in order to make these individualized decisions. I think biomarker research is difficult, but it's incredibly important. Now, do we have effective biomarkers in kidney cancer? I would say we have some biomarkers, but we don't have many, and they aren't really being broadly applied. There have been lots of studies into biomarkers, so people have looked at, just off the top of my head, people have looked at things like neutrophil lymphocyte ratios, just based on patients' like peripheral blood samples. People have looked at C-reactive protein levels, and we've seen that C-reactive protein is associated, if you have a high level of CRP, then you're more likely to recur. And then people are looking more into like genomic signatures, doing sequencing studies of the DNA or RNA within the tumor, and determining based on the specific gene mutations how aggressive the tumor will be or whether or not the tumor will respond to certain types of therapy. There was a paper that came out, Dr. Motzer's group from Memorial Sloan Kettering. They looked at transcriptomic analyses and kind of classified kidney tumors into specific subtypes. And some of those tumors were more or less likely to respond to certain therapies. And so that's kind of the way the field is moving, but none of these have been broadly applied, and none of them are really routinely used in practice. And so that's our goal, is to find one that we can use routinely.
And it seems like there's a lot of work being done in that area, a lot more work that needs to be done. And kudos to you and the team for trying to forge ahead. Because with these biomarkers, then that sort of is the epitome of personalized medicine, right? You can tailor the treatment based on genetic profile or the actual individual tumor characteristics. I think I spend a lot of time talking to patients with various cancers that no two cancers are the same. Like you might see, 5 different patients in your clinic with kidney cancer, but they all have different, phenotypes and genetic alterations. And I mean, that makes managing some of these patients in 2023 somewhat challenging, would you say?
Yeah, definitely. I think what you're really getting down to is tumor heterogeneity. And I think that's the real challenge, again, with biomarker research is tumors are very heterogeneous. You look at one area of a tumor in one spot versus another part of the tumor in another spot, and you can get very different, genetic changes. You get differences in the immune microenvironment. And so how do you have one biomarker that captures all of those differences and all of that heterogeneity within a tumor? That's what's really challenging. But we're up for the challenge, and the research that we're doing here at UW, we're investigating those areas of complexity. We're looking at tumor heterogeneity and trying to find a way to account for tumor heterogeneity. The studies that we conduct, we're sampling tumors in dozens of locations and comparing the differences in all these various areas of the tumor and trying to figure out, is there one aspect that we can look at that is the same throughout the tumor and potentially could be targeted or used as a biomarker? And so, while these are challenges, I think we're up for the challenge and we're making progress in figuring these things out.
I want to move a little bit away from the heavy science. That's really important stuff.
Yeah, it's a little early for all this.
Right. And some of our listeners might be more curious on the clinical side of things, especially if they're treating patients with kidney cancer. And we touched a bit on UW approach to renal mass biopsy. So I just want to go back to that for a minute or two. What is the approach? I remember when I was going through training, it was you only would biopsy a renal mass if you thought it was a metastatic lesion or a lymphoma. And I trained elsewhere. But what is UW's approach, and how has UW advanced the field of renal mass biopsy?
Yeah, so a lot of the work that has been done at UW has been done by my colleague and mentor, Dr. Abel, who's really advanced the science and the field of renal mass biopsy. And at UW, we use renal mass biopsy pretty broadly, I would say, compared to maybe some other institutions. But I think it's a very effective approach for giving the patient more information about their tumor. I would say renal mass biopsy is definitely indicated for patients, kind of like what you said, where we're unsure of what the diagnosis is. Perhaps there's question if this is a benign lesion versus an actual cancerous tumor. And so in those patients, we'll use a renal mass biopsy in order to determine, is this a cancerous tumor and does it warrant further treatment? But then there's also patients where we're deciding on what type of treatment. If we're going to do an ablation, we like to get a biopsy beforehand, because if it is a benign lesion, then obviously we don't want to submit the patient to an ablation. But also, it gives us information of how to follow the patient after the ablation. If we biopsy a tumor and it's cancerous and then we ablate it, we have to continue to follow the patient to make sure the tumor doesn't come back. And so we definitely make sure that we have information before the tumor is destroyed about what the tumor was. And that helps us tailor our approach for following the patient going forward. Also, a lot of patients I find actually want to know what their tumor is before we do a surgery or an ablation, or even if we survey the tumor. I think it provides a little comfort to the patient knowing that we're heading into surgery to remove a truly cancerous lesion. So I think it does provide information to the patients, and oftentimes I get patients who ask for a biopsy before we proceed to surgery. But in general, I would say we definitely use biopsy whenever there's a question about what the optimal approach for the management of the kidney tumor is. If you have a patient who's very old and maybe is better served with just surveying a small renal mass, sometimes then, biopsy may not be indicated, because regardless of what the biopsy comes back as, we will continue to survey that patient regardless. And then in very young patients, sometimes we maybe avoid a biopsy because we don't want to survey the patient for, the decades they have left to live. And so then we may just proceed with a surgery to remove a small renal mass. But it's more in the middle of those gray areas that we use a biopsy to really determine what the best treatment is for a patient.
Yeah, and I think the UW series has really shown the safety profile and low risk of bleeding and complications in over 1,000 patients that have had renal mass biopsies. So kudos to the urology team, Dr. Abel, yourself, and
Yeah.
our radiology colleagues have also been instrumental in advancing the renal mass ablation program here at UW, and that's been a really close collaboration. I know we've sort of touched on ablation several times, so maybe we could just spend a few minutes talking about the ablation program, how UW Urology and Radiology have advanced the ablation field, and then who are we ablating and who do we think are good candidates for that?
Yeah, so we do a fair number of ablations here at UW with our radiology colleagues. So there's different types of ablation modalities. So there's cryoablation, which basically uses carbon dioxide to freeze tumors and destroy them using very cold temperatures. There's radiofrequency ablation, which is more of heating up the tumor to destroy the tumor. And then what we've been using a lot at UW, which is a little bit unique compared to most other institutions, is microwave ablation. And there are theoretical advantages to microwave ablation. It's oftentimes a lot faster than the other treatment modalities. Also, microwave ablation effectively destroys the tissue, and the surrounding tissue doesn't affect the ability of the microwave ablation to destroy the tumor like it does in other thermal ablation modalities, which is getting a little bit technical, but the microwave ablation does have theoretical advantages over other ablation modalities. And so we've been primarily using microwave ablation. And the ideal ablation candidates, it's a difficult question to summarize with one statement, but I think in general, ablation is a good option where you've got kind of a borderline tumor that's growing and is, we've done a biopsy and shown that it's a kidney cancer and it's growing, but the patient maybe is very comorbid and surgery would be a very high risk for complication and morbidity from the surgery. And so ablation may be a less invasive option for that patient and still effectively control the tumor. And ideally, we like to treat tumors that are on the smaller side because we know that as tumors get bigger, there's a higher risk after ablation of the tumor coming back. But with small tumors, we very effectively can control those tumors without any sort of tumor recurrence, and we avoid the morbidity of a bigger operation like a partial nephrectomy. So those are kind of the ideal patients who have smaller tumors. Usually less than 4 centimeters is ideal, but we have ablated larger tumors in sort of more complex situations. But the smaller tumors in a patient who has comorbidities and is a high-risk surgical candidate, those are kind of the ideal ablation candidates.
Perfect. And just to add, I know you guys have also done some ablations on metastatic lesions in patients with kidney cancer that maybe aren't good candidates for surgery to do metastasectomy. So
yeah, definitely. Sometimes patients with metastatic, not even kidney cancer, but just to focus on kidney cancer, maybe they have a solitary metastasis in like an adrenal gland or a lymph node or even like in the subcutaneous space. If it's just one lesion, we can potentially avoid the morbidity of an operation and do an ablation and effectively control that tumor. So we use it sparingly in metastatic disease, but it is an effective treatment modality for these, what we call oligometastatic patients.
Excellent discussion, Dr. Shapiro. It's been a real pleasure having you. I just wanted to summarize a few of the things that we've talked about. We've really covered a lot of topics. We talked about radiomics and a lot of work being done in that area. Potentially could replace a renal mass biopsy in the future, hopefully sometime in our careers. That'd be awesome to see. That's a really exciting area, working in close collaboration with our radiology colleagues. Then we moved into sort of the immune therapies, checkpoint inhibitors, as well as the immune microenvironment, how cancer evades our own immune systems. There's a lot of work and science being done by your group in collaboration with pathologists, which is really exciting. And hopefully through that science, we'll be able to develop some novel biomarkers, sort of the holy grail to personalized medicine.
Yes. Yeah, exactly.
And then we spent a good amount of time talking more about some of the clinical pearls regarding renal mass biopsy, some of the innovative advancements that we've made in ablation at UW in collaboration with our abdominal imaging radiology colleagues. Really exciting stuff, Dr. Shapiro, and it's really been a great pleasure having you on the program this morning.
Well, thanks so much. Thanks for having me, and thanks for putting on such a great program.
I want to thank Dr. Nakata and the Department of Urology for sponsoring this, and I want to thank all our listeners out there for tuning in. We look forward to putting out some more of these podcasts in the future on exciting and innovative topics that hopefully will get people talking about and thinking about advancing the field of urology. Have a great rest of your day, everyone, and thanks for tuning in.
Winnovations is a production from the Department of Urology at the University of Wisconsin-Madison School of Medicine and Public Health. Thanks for listening.